sweet. You were my voice when I couldn't speak. You were my eyes when I couldn't see. You saw the best there was in me, lifted me up when I couldn't reach. You gave me faith 'cause you believed.
Good morning, Professor Homa. Good morning, fellow classmates. It's Cheryl here. I'm going to be giving you a presentation on Virginia Henderson. I know my introduction may have been a little bit corny, but I do think that the words of Celine Dion's song do speak to some of which Virginia Henderson tried to explain in her concept of nursing and in her need theory. Virginia Henderson was born November 30th, 1897, and lived an amazing life until March 19th in 1996. Throughout her lifetime, she was an educator, a researcher, an artist, a scientist, a theorist, a philosopher, and a humanitarian. But above all else, she was a nurse, and she was a nurse first and foremost. She was often referred to as the First Lady of Nursing. She was also referred to as the foremost nurse of the 20th century, as well as the first truly international nurse. She was born in Kansas City, Missouri, to Daniel Henderson and Lucy Abbott, her parents. She lived in Kansas City until about the age of 4 when they moved to Virginia. There she went to Bellevue Preparatory School and then furthered her education beginning in nursing at the Army School of Nursing in Washington, D.C. She graduated there with a diploma degree in nursing in 1921, and she attended the Teachers College at Columbia University, 4 classes for this school. After her graduation, for about 2 years, she was a visiting nurse for the Henry Street Settlement in New York City, and then in 1924 she accepted a position as the first and only teacher at the School of Nursing in Norfolk Protestant Hospital in Virginia. She was there until about 1929, when she returned to Teachers College to obtain her bachelor's and master's degrees in nursing. She then became a nurse educator at Teachers College and continued with that for about 16 years. Now, while she was at Teachers College, she also worked as a practicing nurse at the teaching hospitals within New York City, and in 1939 she was asked to revise the edition of the Harmer textbook, which was a reference text for nursing education. So she did that and did the 4th edition in 1939, and then in 1955 she did the 5th edition, which was now known as the Harmer and Henderson Textbook of Principles and Practice of Nursing. Within this 5th edition was where her first concept of nursing was put in the literature. She said here that nurses assisted the individual, sick or well, in the performance of those activities contributing to health, its recovery, or to a peaceful death, that they would perform unaided if they had the requisite strength, will, or knowledge. In 1958, the International Council of Nurses asked her to publish or describe her concept of nursing, which they published in 1961. It incorporated the original description that she had put in print in the 5th edition in 1955, but to it she added to the end that it would also do this in such a way as to help the patient gain independence as rapidly as possible. And that is really what we see as our historical concept of nursing, what we have come to know as the historical concept of nursing. Any nurse educated from 1950 to 1975 really were readily aware of her concept because Henderson's textbooks were used extensively in teaching any learning nurse the fundamental skills and concepts of nursing. In 1972, she became a Yale research assistant, and she developed the Nursing Studies Index, which I'll explain on the next slide, and they were a pretty big deal. At the age of 75, she began a 5-year endeavor to create the 6th edition of the Principle and Practice of Nursing. In 1953, Henderson began working at the Yale School of Nursing. She was a research associate, and during this time she did a critical review of nursing literature. She found 2 significant discoveries during this critical review. She discovered that most research studies study nurses themselves, not the care which was provided. Henderson also found there was a lack of organization for which to base the clinical studies. So this ended up creating a more clinical orientation for nursing research. It led to her development of the 4-volume Nursing Studies Index. And she was able then to incorporate this indexed information into the 6th edition of the Principles and Practice of Nursing. The Principles and Practice of Nursing is considered to be the single most important professional document of the 21st century. Henderson herself believes that the Nursing Studies Index was her most important work and her most important contribution to nursing research. The Nursing Studies Index was a compilation of biographical, analytical, and historical literature from the nursing research from 1900 to 1959. And the sixth edition of the Principles and Practice of Nursing, which incorporated the index, was a vast textbook of knowledge. And just to give you an example of its scope, there were 50 chapters, a total of 2,119 pages, and Chapter 3 alone contained over 1,000 citations. Interesting to note that it is void of medical terminology because she wanted this to be an aid for anyone who needed to care for an ill individual. From Henderson's concept, she developed her need theory, which identifies the 14 needs in order to manage a patient and care for a patient in a holistic manner. I know we all know what these 14 needs are, so I'm not going to read them all. I'll address them when I do the clinical scenario. Within the need theory, there are two assumptions. The first assumption is the nurse is willing to assist the patient. This means the nurse is devoted to the patient and they will assist the patient at all hours of the day and night. Additionally, the second assumption is that the patient wants to be helped, wants to have optimum health, wants and desires to be free from illness. The concepts from the nursing meta paradigm include a person as anyone sick or well needing assistance to perform one or more of Henderson's components. It's important to note here that Henderson believed that the mind and body are inseparable and they are also interrelated. The environment is not clearly defined, but it is certainly implied within the 14 components, and it definitely includes all conditions that affect a patient's life and a person's development, which includes their family as well. Health is the goal of the need theory, is described as the independence in the ability to maintain all 14 components, and nursing, of course, is the person who assists the patient in the ability to obtain the independence. When we apply Henderson's need theory to the clinical scenario, it's interesting because for a grand theory, she is clear and concise, and it is actually applicable to the practicing nurse. I think that's important to note as we attempt to bring nursing theory back in and incorporate into nursing education, be able to apply it directly to our practice, as many grand theories are not able to be done. Henderson's work has been used in childbirth education. It has been done in mental health. It's been done in alcohol rehab, in AIDS patients. I mean, the list goes on and on. But in my clinical scenario, I am using it in the application of organ donation after brain death. Now, nurses are typically transplant specialists. They can be from other healthcare areas, but typically a nurse is a transplant specialist who was specifically trained in organ procurement. They would be the coordinator from the care once they are consulted for the patient who has been determined to be possibly brain dead. They work through the process of that determination, and then they assist in maintaining the patient up until the time of organ procurement, and actually even a little while afterwards. Nicely and Delario did a wonderful job, and I have referenced them at the end of my presentation, where they discuss this application to organ donation after brain death to the patient and to the family. In that, they say that a nurse can be the voice unheard, ensuring that the decisions the patient made while they were still independent are realized. And that's important because we are definitely want to incorporate the patient's needs, but they are at this point unable to direct us to that. When we apply Henderson's need theory, we see that the patient, of course, we need them to breathe normally, but this patient is not able to do that anymore. So we must maintain adequate oxygenation, and this is typically done through ventilatory support. Eating and drinking adequately, again, the patient cannot do independently, but we would administer fluid and electrolytes as needed, blood transfusions as needed, and are obviously common when we have a traumatic event that results in brain death. We also would need to administer medications to prevent volume depletion, such as desmopressin and mannitol. Nutritional support is being looked at as being potentially beneficial. I haven't seen it in practice, but that is being looked at. Elimination of body waste definitely comes into play because of the effect of ADH which stops completely after death and certainly is decreased with neurologic damage. So kidney function and the effect on body organs needs to be monitored with labs and hemodynamics. Moving and maintaining desirable positions and sleep and rest are discussed together by Delario and nicely. In brain death, all voluntary function for movement is lost, so the patient who is brain dead must be treated basically as any bedridden patient would be, with attention to skin care, mobilization for, if we're going to be retrieving lungs for transplantation, we certainly have to make sure that they don't develop a pneumonia or infiltrates and whatnot. Number 6, as far as this, is the select suitable clothing, dress and undress. The patient obviously cannot do that, but as nurses, we would be maintaining privacy and modesty for the patient, and this shows a respect for their dignity as well, and which is very important, obviously, for the family. Number 7, maintaining body temperature is always an issue with a brain damaged patient. Regulation is often difficult due to the damage to the hypothalamus, so warming or cooling as appropriate would be necessary, as the patient could become potentially hypothermic or hyperthermic, and this certainly will affect blood pressure, will affect distribution of oxygenation. There's a variety of effects there, and it is certainly something the nurse must maintain. Keeping the body clean and well groomed and protecting the integument is another area which is very important, and actually the family can be involved in this if they would want to be. Basic grooming definitely maintains dignity of the patient. It shows that we care about the patient. We're not just, going to be taking, the parts away from the patient, but we respect him as a whole. Basic grooming also allows for a less traumatic visual for the family. Oftentimes patients who arrive and end up to be brain dead have had this happen through a traumatic event. So cleaning up the patient is certainly important. Avoiding dangers in the environment and avoiding injuring others pertains to the maintenance of the physical environment, such as the equipment which we're using to maintain the patient, but it also means to protect the emotional environment of the patient and staff. We're ensuring the emotional support for them and kind of trying to control that through education, through support, and that also leads into communication with others and expressing emotions, needs, fears, and opinions. Communicating with the family and staff is very important. In organ donation, the nurse caring for the patient really should only speak to the patient until the time brain death is determined. Once brain death is determined, the nurse actually no longer should be speaking to the patient. It can develop some confusion on the term, by the family. They also recommend use of specific terminology to enhance the understanding that this is the end of life as the family starts to understand the process. Worshiping according to one's faith. This can allow the nurse to look at her own spiritual beliefs, but it can also be portrayed onto the family as the family and the staff of the hospital are experiencing a highly emotional time. Using religious resources is certainly something that can be and should be utilized as necessary, as this is very supportive to everyone involved. Working in such a way that there is a sense of accomplishment is not necessarily discussed by Nicely and Delario in the paper, but most families, at least in my experience, have said that at least this step has served a purpose if the patient is able to help another person. Additionally, the nurse who is caring for the patient must also realize this. To learn, discover, and satisfy curiosity can certainly be applied to patients, families, and staff who would benefit from any additional information, counseling, and supportive services related to the grief and to the process of organ donation. As I conclude about Virginia Henderson, I really need to just add one last thing. She was a huge proponent of nurse autonomy. One of the things which she says, which I absolutely love, is the complexity and quality of the service is limited only by the imagination and competence of the nurse who interprets it. She added that I would like to emphasize that I am not presenting my point of view as one with which I expect you to agree. Rather, I urge every nurse to develop her own concept. Otherwise, she is merely imitating others and acting under authority. It is easy to see through her need theory and through her concept that she encourages nurses to be independent practitioners, to work along with the medical team, but to bring their own unique knowledge. I hope I have enhanced your knowledge of Virginia Henderson. I thoroughly enjoyed learning about her and all of what she has brought to the nursing profession. Thank you.